All right, and welcome everybody to our Wednesday morning orthopedic surgery grand rounds. We have a very special visiting professor today, and for our introduction, I'll turn it over to Dr. Morshed.
All right, I'm eager to introduce today's Grand Round speaker, Dr. Bob O'Toole from the University of Maryland and the R. Adams Cowley Shock Trauma Center in Baltimore. Dr. O'Toole's received his bachelor's and master's degree in mechanical engineering from Carnegie Mellon and Stanford, respectively. He then went on to study medicine at Harvard, where he graduated with high honors. He stayed at Harvard to complete his orthopedic training, and from there on to shock trauma, his orthopedic fellowship, and would later join the faculty in 2005. Since that point, Dr. O'Toole's academic trajectory has been extraordinary. He's authored over 170 peer-reviewed manuscripts, written 18 book chapters. He's been a PI of no less than 8 papers that have received the top 10 designation at the annual meeting of the Orthopedic Trauma Association. He's served on many committees, many of which he's chaired. He's served on the board for the OTA and chaired the program committee over many years. His service and educational accomplishments have been awarded with really on too many occasions to count here. He currently holds the Hans-Jörg Wisk Medical Foundation Professorship in Orthopedic Trauma. He's director of at Shock Trauma, as well as head of the Division of Orthopedic Trauma and Chief of Orthopedics at Shock Trauma. As if he isn't busy enough, Dr. O'Toole's an accomplished clinical trialist. He served as PI of numerous influential trials investigating compartment syndrome, as you've heard about, as well as various modalities for mitigating postoperative wound infections and preventing venous thromboembolism in orthopedic trauma patients. He was recently promoted to lead the METRIC Consortium as its clinical chair, and thus assuming one of the most influential positions in orthopedic trauma research. Despite his mind-boggling clinical, academic, and research accomplishments, I know Bob to be extremely humble, sincere, and personable, as you've witnessed here this morning. So I'm a bit sad that we don't have the privilege of hearing from him in person today. But his virtual presence with us is still a pretty good thing. This morning, Dr. O'Toole will surely enlighten us on the clinical dilemma of diagnosis and treatment of compartment syndrome. Bob, thank you very much for being here. And with that, go ahead and take it away.
I really appreciate that. That's an incredibly flattering introduction, so thank you very much. And let's see if I can. All right, you guys see that okay in presenter mode?
Yes.
Perfect. All right. Well, thank you. I really appreciate being given the opportunity here to speak today. It truly is an honor, and I'm excited to talk about this. Before we get started, I just want to give a couple minutes about shock trauma. When I was a resident, this is in a Grand Rounds, a guy named Andy Burgess, who you may know, came to my residency and gave a talk, and I'm certainly no Andy Burgess, but everybody in the world has heard of UCSF. Not everybody's heard of shock trauma, so I thought I'd give you just a couple words on what is shock trauma. So shock trauma is located over here on the East Coast in Baltimore. It's in the state of Maryland, which you may not know is actually a super wealthy state, believe it or not. So we're #1 in median household income and low overall crime rate. This is contrasted with Baltimore, which is not a super rich place and has charming facts about it, like leading the country in syphilis outbreaks and things like that. And so they named it Charm City in the 1970s. Instead of trying to fix the problems, we thought we'd just call it Charm City, and that would do it. Here's the guy that the place is named after, R. Adams Cowley. His first name is R. There's no period after it. And the reason for that is when he was born, his mother was promised a bassinet if she named him Rufus. And so after the delivery happened, she didn't like the name Rufus. And so she just wrote an R on the birth certificate, and that's it. And so that's why his name is R. Adams Cowley. And he came up with the idea of the golden hour, which is totally non-evidence-based, but the golden half hour didn't sound very good. So he just picked golden hour. And it's this idea that you got to, take care of people quickly. And this idea of having specialized trauma centers and helicopters around the state and all that stuff, that he's the one who did that. So it's a weird place in that it's just a trauma center. So we're a big place, about 8,000 trauma admissions, but as a hospital goes, we're actually very small. And we only have general surgery, like there's no internal medicine in our hospital. We're in part of a regular University of Maryland. Andy Pollack is our chair. He's also happens to be an orthopedic traumatologist. There's a bunch of our faculty. So we have 13 faculty. You'll notice Dr. Langhammer at the top of this image is doing a great job for us. So thank you. And for the residents we should know, we're very NP run. So the floors are run by very experienced and skilled nurse practitioners, as are our clinics. We have 8 programs that come to us from around the country that rotate with us. And we have a fellowship. It's a great time for the field. We have really qualified people applying in orthopedics. You just heard one of them present. And we just have a lot of talent going into ortho trauma right now. So it's a great time for our field. And in terms of us, we run about 4 trauma rooms a day at Shock, and then we're at other facilities too doing our elective stuff. And we're lucky that our volume just keeps going up. Our system is set up in a way that we've not had problems with other level 2s and things pulling volume away from us. So we're really lucky in that. Just a word on our clinical research. The place has changed a lot in the last 15 years. So as Sam mentioned, we're into it. And so we have 13 full-time clinical researchers. We run about 16 prospective trials at a time, and we're proud to brag that this metric thing, we're the #1 enroller. And here you can see our research manager receiving a fake award that we gave to ourselves for this. And so that's shock trauma. Now you can say that you've heard of it. I can tell you all sorts of stories about the fake award if you want to hear about it later. But compartment syndrome. So why don't I talk about compartment syndrome? So I really like compartment syndrome as a grand rounds talk. And the reason I like it aimed at residents, fellows, and faculty too, is because almost everybody cares about this, right? So you're the resident out there, you're saying, I don't need to know this because I'm going into spine and I need to know about how many boats I should have, but I don't need to know about compartment syndrome. And the reason why you still have to know about it is you have to take call. And this is the only thing the trauma center may say no. So people call us and say they have compartment syndrome, and we say, I can't get them here. I can't get them here for 8 hours. So you got to do it. And so this is something an orthopedic surgeon really has to know about. None of the conflicts are relevant for this. I want to acknowledge some people in particular. Chris Doro, he's a smart guy, University of Wisconsin, taught me a lot about compartment syndrome, and you'll hear some of his ideas in this talk. All right, so in the next little bit, we're going to talk about what do we know about compartment syndrome, really just go through the dogma of what we have. Then we'll revisit each of those pieces and see is any of this stuff actually true. And then we'll end with just a few new ideas on diagnosing compartment syndrome. So here's Volkmann. I'd like to show his picture. He's got some awesome looking facial hair, and he's the one who's attributed as being the first to describe this. And he thought this came from bandages interrupting arterial supply. In the 1970s, most of the stuff that are kind of the basis of how we think about things came about sort of simultaneously. This idea about pressure, decreasing blood flow, that sort of occurred in the 1970s. Here's a diagnosis of compartment syndrome. I just want to read through this very briefly, and we're going to return to this later in the talk. So the idea of compartment syndrome is the pressure within an osteofascial compartment rises to a level that decreases the perfusion gradient across tissue or capillary beds, leading to cellular anoxia. So that's the key, we think, in compartment syndrome, and cell death. We'll come back to that. Most of the research is in the tibia. So if you look in tibia shaft fractures, the proportion of patients who get a fracture is around 1 to 11%. It's more common proximally. So there's a study out of our site looking at this. So plateaus, have a 12% proportion of them, whereas pilons are low, but it's not 0. The thought for that is that there's more muscle mass up proximally, and there's a big venous supply around the knee. It's not just one study, lots of studies show. So, yep, we need to worry about it when we see a bad bicondylar plateau, that there's a real risk here that they have compartment syndrome. If you look at ballistic fractures, so here's a study that looked at ballistic fractures all over the body. And once again, tibia pops up, but interestingly, fibula pops up, particularly proximal, even isolated fibula. So that's a high proportion of patients who wind up with compartment syndrome with what seems like a very benign injury. And I've seen that missed to devastating consequences. Other risk factors from the literature are young age, male gender pops up over and over again. Length of the fracture has popped up recently. So here's a picture of this. This was shown in the case conference we did this morning. So here's sort of length of the fracture, and the idea is that the longer the fracture gets, the more chance probably that there's more bleeding, more indication, more energy. Another one that's been come out, Dr. Zoran's group, and has been validated by another group, is this displacement of the fen-tib axis for tibial plateaus. And it shows as you go to the right here and you get more displacement, you get more proportion of the patients that get compartment syndrome. And also the width, that has also been shown in a couple studies to pop up. So there's definitely some risk factors that we can use to identify, but as we always point out, it's really important to note that you can have no risk factors and still have compartment syndrome. So it's a serious issue. We can lose a limb, you can die from compartment syndrome. And there's no question that in addition to being serious to the patients, it's serious to the clinicians. So we do not do well medical legally with this. We do worse in terms of our settlements, and we have in terms of the money and in terms of losing. So we do worse in terms of a chance that we'll win. Poor documentation is always the issue. And so that comes up as, what should I document? The resident asks that question. And so I would say that you need to think a little about who you're documenting for. What is the purpose? And I think there's two people. So one is the other clinicians, right? It's your co-resident, it's your co-attending who's going to be at the bedside at 2 o'clock in the morning. And the other, of course, is the lawyers who are going to be reading this. And they're going to be reading it in 5 years. You're not going to remember this case. You don't remember anything about this. All you're going to have is your note. That's all you got. And so we do some stuff that isn't great, right? We write NVI, neurovascular intact, right? We probably should never write that. You didn't really examine the obturator nerve. That's not going to be very helpful to another clinician, right? Did you take the splint down? What do you mean they're NVI? What's that mean? So how about Wiggles toes? So I like Wiggles toes. Wiggles toes is way better. So Wiggles toes is honest, right? Wiggles toes says, the patient can either flex or extend their toes. I'm way too lazy to touch the patient, but they can do something. So that's helpful, right? Because at least it's honest. But probably as orthopedic surgeons, right, we can do better and be a little more specific. The one thing that one of my mentors taught me, which I think is useful, is in these patients to write down no evidence of compartment syndrome at this time. And so you thought about compartment syndrome, here's the time and date, you don't think they have it. And that's the mistake you see in a lot of these cases, is that when you go back and look at them, nobody actually writes down they didn't have compartment syndrome. There's 3 nursing notes that say 10 out of 10 pain. The resident came by 3 times and didn't write a note. And so I think that's a useful thing. So I think there's consensus on the importance of this in terms of being a devastating injury. There's consensus that there are significant medical legal issues you need to be careful with. And there's also consensus on the treatment. So time matters. And unfortunately, there's not many spots left where time really matters. Or fortunately, I should say, in ortho trauma, but this is one of them. So we got to rush to the OR. And the treatment is still decompressive fasciotomies. Nothing's changed here. The animal data is very strong that time matters. There's a critical time point beyond which it doesn't help if you release them. There'll be no randomized trials on this, but the clinical studies are all consistent. There's a consistent signal that late release leads to worse outcome. The other argument here is there's no theoretical benefit to delay. When people want to do a displaced intracapsular femoral neck fracture in the middle of the night in a 25-year-old, that's a hard case, actually, and you need certain equipment. It'd be really nice to have a tech who knows what a drill is and what size drill bits there are. You don't need that for this, right? All you need is a knife, any table. So there's no advantage to the patient of delaying in this situation. There are several kinds of fasciotomies that are commonly done. One is the forearm fasciotomy. I'm not going to go into great detail of that, but just remember, in forearm fasciotomies, typically we don't release all the compartments, actually. We don't release the dorsal compartment. We just check it and see what it's like. And similarly in the thigh, we don't actually release all the compartments. What we tend to do is release laterally. We just check medially. So it's really only the leg where we actually release all the compartments. And there's 2 ways of doing that. And so this is one of those skills I would argue as an orthopedic surgeon, you have to know how to do this because you may be called on to do it. You can't transfer the patient. So there's 2 ways of doing it. There's the 2 incision and the 1 incision. And so I'm just going to run through quickly a 2 incision video. It takes just a couple minutes. Let's see if I can get this to go. All right, here we go. So I did not make this video. This was made at Shock Trauma many years ago. And this is a patient's leg. Their foot is to our left. Their knee is to our right. So we're on the lateral side. The incision is a couple centimeters anterior to the fibula traditionally. Anterior in this is the anterior compartment, and towards the bottom of the screen is lateral. So there's the intermuscular septum. They're going to release the anterior compartment first. You're seeing the anterior compartment musculature there up above, the darker muscle that doesn't look so good. The nice red muscle down below is the lateral muscle. So, you're going to take some care to look out for the superficial perineal nerve, and you're going to release the anterior compartment here. I think it's fine to slide underneath the skin. Some people don't like that because it risks, catching the SPN. But you really want to have full releases here. This is not like releasing pressure in a balloon. You can't just pop it and the pressure all comes out. So if you don't release it completely, the muscle will start dying, will be dead geographically right at that spot. So they release distally in the lateral compartment. Now they're back up into the anterior compartment, coming up proximal towards the knee, releasing under the skin flaps. Now we're going to go back to the lateral compartment and releasing that. So nice complete release, big incisions. This is not exertional compartment syndrome. You're not trying to make small incisions, big incisions, big complete releases. And then you're going to check the muscle, see if it's contractile. And you can see this anterior compartment does not look so good. This lateral compartment looks great. Now we're going to turn ourselves over to the medial side after checking out that muscle. Make the incision here a couple centimeters posterior to the tibia. And you're going to come down through here. You know, people often say that all approaches in orthopedics go through the saphenous vein. You'll see an example of that. There's the saphenous, and they're dissecting down, and they're about to cut it, and they edit away very cleverly. So you may encounter the saphenous there. And so you're going to release the superficial posterior compartment, which is being done right here. And then you're going to get to the tibia and get behind the tibia, and that's going to release the deep posterior compartment. Some people think you should come up and take off the soleal sling where the soleus attaches onto the tibia. If you look at what people incompletely release this, your colleagues who usually in other specialties who aren't as experienced, the common mistake I see made is they do not release the anterior compartment. They don't release the deep posterior compartment, and they release the superficial posterior compartment twice, once from each side. So it's just, and often they're doing it for prophylactic fasciotomy, so it doesn't matter, but be careful, right? So if someone else releases the fasciotomy and you're taking care of that leg, you probably should, if you can, it's tough sometimes socially, but you got to poke your head in there and make sure they actually released all the fascia, because they may not be as experienced as you are doing this release. So here you see this release that's happening behind the tibia. And these are also big, big wound again, medial side and the lateral side. All right. So that's the 2 incision version. You're going to release the anterior and the lateral, as we just saw, through one incision, and the deep and superficial posterior through the other. So there's an argument to do a 1 compartment or 1 incision fasciotomy. So there is, right? So many of us in this call are very aware that tibial plateaus and compartment syndrome have a problem. And so when we release these fasciotomies, you might be able to stay out of this wound by, doing something special and doing percutaneous incisions when you go back to fix this plateau fracture. But we're recognizing that there's a big problem in terms of a deep surgical site infection. So without a fasciotomy, the proportion of patients that get infection is 8%. With its 23%. We're currently doing a multi-center retrospective look at this with much bigger numbers, and the same number comes right through. So a quarter of the patients are getting infected. So big problem. So what could we do? And so, inevitably we wind up going back through this medial fasciotomy wound, and we go medial for a Schatzker 6. And so maybe there's something we could do. And so one thing you could do is maybe you could have a smaller fasciotomy footprint and do 1 incision. And so the idea of a 1 incision fasciotomy is you can see how you could easily get the 3 compartments from the lateral side. But how do you get the deep posterior? And so there's a beautiful, I'm not going to go through it, but a beautiful paper out of Harborview on this, on single incision fasciotomy with some great pictures. But for me, the issue with it is, I think if you're not very familiar with this, the 2 incision fasciotomy is technically just easier. If you're a trauma person or somebody who foot and ankle is comfortable about going around the back of the fibula, posterior lateral approaches, I think this is fine. But for me, for someone who's just a basic person who isn't doing this very often, I think two incision is simpler to make sure you get everything released. So there's consensus on the importance of this. It's a devastating injury. There's consensus that time matters, and that decompressive fasciotomies are the treatment that we need to do. What about diagnosis? So that's where the trouble starts. So we're taught in medical school that it's a clinical diagnosis. The P's are the key, and here we have all these P's. And that sounds great until you try and start to do it. How much pain should a heroin addict have in the PACU after tibial nail? They tend to have a lot, has been my experience. So what's out of proportion? I don't know. So there's the one I really want to point out that's particularly problematic is pulselessness, just to make sure we're all on the same page. So 85% of people with compartment syndrome, we think, have stone cold normal pulses. So unfortunately in the ED and nursing literature, this isn't so clear. And so you'll say, oh, well, the patient, they have normal pulses, so we didn't call ortho. And so that's a big problem. So, yep, if they have abnormal pulses, you should be worried. But if they have normal pulses, you shouldn't say everything's fine. And each of these P's has problems. And there's studies showing that we're not so great at it. So it's a real difficult area. For the residents, remember, you need to ask the patient to close their eyes. It's amazing how inaccurate an exam you can get if the patient's eyes are open while they're watching you touch their feet. You really need to close their eyes so they really are feeling, and there's no miscommunication. Pressure measurements. So the dogma now is we're going to confirm this by pressure measurements. There's normal compartments have low pressures. There's a great study by Dr. Heckman many years ago that shows as you get closer to a fracture, the pressure rises up. And this is it, right? Like if we don't know what to do, we can always check the pressures, and we get a delta P of 30. So if the pressure within the compartment rises within 30 of diastolic, it's a yes, and they have compartment syndrome. If you look at where this number comes from, this is one of the, I would argue, 2 most cited papers in the field, and it's by McQueen, probably the most well-known researcher in the field. This is where this delta P of 30 comes from, this paper from 96. And so I think this paper does a great job of knocking out the current dogma at the time, which was that absolute pressures are important, because they had a bunch of people with absolute pressures they didn't release who did fine. Now, there were only 3 cases in this, but this is the thing that we go back and look at. And what's important to know is this is actually pretty different than what we use it for. So we use it for what we should do when you do a single pressure measurement, but that was not done at all any time in these cases. They actually monitored them with continuous slit catheters. And so the values were analyzed in 12-hour blocks and they averaged them. So they didn't use any single value data, but this is how we extrapolate it from. Most people don't read the paper and look at it, right? So it's just important to know that the basis of this is not what we do. Now, what if you're in the OR? Does it matter? Does something happen to their diastolic in the OR? And which pressure should I use, pre-op or intra-op? So this is, to me, one of the best papers I've ever seen in terms of cleverest amount of little effort to get a paper. So basically, Paul Ternetta's team looked up the diastolic pressure pre-op and intra-op. That's it. That's all the data collection, and then published it. And it's brilliant. So what they showed was your diastolic pressure drops about 20 points in case patients who are having a nail. So that's useful, right? And so Paul's interpretation of this is, look, if this is just transient, so you should use the pre-op. That's going to be their diastolic. If you're going to be in the OR for 10 hours, you probably should use the intra-op. I mean, it's real. That is their diastolic blood pressure, but it's probably going to be higher later. All right, so that's a whirlwind tour of the dogma. That's kind of, where we are, I think, in 2021 and what you have to know as a resident or attending. Now let's think about, is any of this stuff true? So the first piece is, do surgeons agree on compartment syndrome? Seems pretty straightforward. We use the P's, we got the pressure measurement if we're not sure what to do. And so this paper came about because some years ago, we had 2 attendings who still work here who trained in fellowship the same year. And they went out and practiced, came back here and were attendings. And one of them walked into a room, saw the patient, examine him, came to the other person who he'd known for years and said, hey, do you mind covering that case in room 3? I got to go. I examined him. The patient does not need to be released with compartment syndrome. They're just a little swollen. Perfect. Attending walks out, the other attending walks right in the room, touches the leg and says, he needs to be released. He has compartment syndrome. And so that's interesting, right? Like, do we all agree on this? And so what we did here is we looked at patients who had tibia fractures, and you would think that we'd all have about the same rate of release if we're seeing the same rate of compartment syndrome. So we just looked at our center, about 400 patients, and we looked at the attending record. At the time period, people were taking call on random days. It's 7 attendings, and looked to see if we have a similar rate of fasciotomy. And so our overall rate was 11%, which is on the high side actually for tibias. And so do you think we agreed with each other? So we did not agree with each other. Like, we really didn't agree with each other. So some people were releasing 2% of the patients and some people were releasing 25%. And here's that graphically. So here are the 7 surgeons. So surgeon 1 is releasing a quarter of the patients and surgeon 7 is releasing hardly any of the patients. Now you may wonder, well, who was right? Like, what was the true answer? And you can imagine that when we went back and looked through the charts, there weren't a whole bunch of cases where people said in clinic, oh, you know what? I missed compartment syndrome here. Wow, that was terrible. I shouldn't have done that. So that doesn't happen too often in the medical record. Now, if your rate's too high, you're doing unnecessary surgeries. Maybe that's bad. If it's too low, that could be really bad, of course, right? You might be losing limbs and causing terrible things to happen. Now, maybe this variation is just due to our relative value of missed compartment syndrome versus unnecessary surgery. Maybe there's something in how we're diagnosing it. We'll return to that. Maybe there's something in the treatment, like maybe we're causing compartment syndrome, how we do the nails. That's a little disconcerting, right? So we're always taught that clinical signs are good predictors, so maybe we should just focus on that. So this paper, the first time I saw McQueen talk, McQueen got up and was giving a talk about something else and used 6 slides from this paper. Almost every talk she gives, she has many slides from this paper. This is probably the most quoted paper in compartment syndrome, I bet. It's a single author paper. And I actually don't know Dr. Ulmer. I would love to talk with Dr. Ulmer someday. And Dr. Ulmer, I suspect, is very smart. So he used something called Bayes' theorem, which is very popular now, like all these COVID trials or Bayesian adaptive analyses and stuff. But this is long a ways ago and was using Bayes analysis to look at this. And so we won't get into that, what that is, but fancy stats. So thoughtful guy, and is going to look at how good clinical signs are and clinical exam is for diagnosing compartment syndrome. So he's going to pick a bunch of injuries. He's going to go through the literature. He's going to pull out these papers. So there's 4 papers. And so it's not a lot of papers, but they're probably really good papers. And so what he found was there's sensitivity and positive predictive value is terrible, right? So McQueen uses this to sort of as a hammer against physical exam and says, hey, it's not so good, although there's good specificity. And if you lump the findings together, it starts to maybe get better. But I want to step back and think about the most quoted paper we probably have in compartment syndrome. So this is trying to look at a test. The test here is clinical exam. And so if you think about how many patients do we need to validate this test? So if you think about mammography or PSA for prostate cancer, and so in each of those situations, those papers wind up in the New York Times, right? And so how many patients do we need with and without prostate cancer? And so I don't know exactly what the answer is, but broadly speaking, it's a lot, right? You're gonna have a lot of people with prostate cancer, a lot of people without prostate cancer, to thousands to validate the test. So let's see what we did with this. And so I did something weird because she kept talking about how important the paper was, and I was embarrassed I didn't know the paper well. So I pulled it and I read the paper. And then I pulled those 4 papers and I read them. And I read them almost every year actually and look through them. I have my little folder. So here are the 4 papers. So here's the first one. So the first paper they included on figuring out if physical exam works to diagnose compartment syndrome had no patients with compartment syndrome in it. So that's strange, right? Like, how would that be helpful? The next study had 1 patient. The next study had no patients again, and the last one had 3. So in this most cited paper, we only have 4 patients who have the disease. So this makes no sense. And if you read the paper, Ulmer knew it made no sense and said that in the conclusion. He said, there's not enough data to do this analysis. This can't be done. But he did the analysis anyway. And everybody just quotes the analysis, right? They don't actually go and look and realize that really his conclusion was there's no data to do this. So it's this garbage in, garbage out problem, right? Like, he did a really clever analysis on bad data, and that's a problem. And so this is the point of it, right? Like, don't believe me. Like, don't believe me just because somebody told me I could talk at this podium. It doesn't mean I know what I'm talking about. And as residents and surgeons, we have to be very suspicious of each other, right? That just because somebody is well-known or whatever and speaks very enthusiastically about something, it doesn't mean they're right. So beware. So I would say the conclusion for me of that is there's very little prospective high quality data. Even though we say physical exam is supposed to be the most important thing, we don't really know that at all because we don't have much high quality prospective data on that at all. All right, so that's a little disappointing, but let's get to the last piece, pressure measurements. So at least we have pressure measurements. We can always rely on pressure measurements. So Prayson looked at this in the VA population. Prayson took people who didn't have compartment syndrome and stuck them. And so what you would hope is that none of those patients would make the criteria for being positive by pressure measurements. So that was his goal. And so he looked at 19 patients, and what percentage of them had within 30 millimeters of diastolic? Well, that's disappointing, right? We hope that number was going to be 0, and it's 84%. It's 58% within 20. Now, there's problems with this study, right? It's a small sample size. It's got a mixed bag of injuries. It's calcaneus fracture. It's weird stuff in here. Fine. So let's redo it. So we redo it at our site. So we take between about 48 patients, and we look at these patients, and we take patients who don't have compartment syndrome. We examine them beforehand. We take them to the OR. We don't release them. We check their pressures. We ignore the pressure number. We then examine them in the PACU afterwards and document it, and we follow them. Nobody has signs of compartment syndrome at 6-month follow-up, and we didn't release anybody. So we had a standard pre-op exam, as I mentioned. So we'd hope this number within 30 millimeters of diastolic would be 0. So it's 35%. And I would argue that this is actually the lowest you would expect the false positive rate to be. And the reason for that is that no one thought these patients had compartment syndrome. So they weren't swollen. That's how they got in the study. We weren't worried about any of these patients. That's why we were willing to do this. So that has to give you some pause, right? This is our gold standard test. And this has been redone recently in a much better way. So Andy Schmidt led the metric group, and they did this PAC study. And what they did is they put continuous pressure measurements in 150 patients, and they didn't know what the values were, and they followed them all. So you could look at them, but they weren't given the values. Unlike us, we saw what they were. And they looked at their criteria, not just once like we did. They said you had to be within delta P of 30 for 2 continuous hours in order to say yes. So that gave you good negative predictive value, but horrible positive predictive value. So positive value meant nothing. There were tons of patients who were within delta P of 30 for 2 hours. So this really has to make us question what exactly is going on with pressure measurements. And this to me is pretty disconcerting, right? We may have a really high false positive rate with this gold standard test. Maybe we shouldn't be relying on a single test. 1/3 of the patients are getting an unnecessary surgery, maybe. And it's whatever happens when you do a study, right? You then go back after you're done and read some more papers and realize this has been known for a long time. Other people knew that delta P of 30 is not the right number, and damage doesn't really happen in animals at this level. It has to be a much higher pressure before this happens. Now, that doesn't mean just because your delta P is less than 30, you have compartment syndrome. What it tends to say is that because if you're beyond that threshold, you're safe. If you go back and look at that original, the first paper I showed you, here's our 7 attendings. Attending 1 releases a lot. And then you ask, how often do each of those attendings check pressures? It's the same graph. In this time period, if you had your pressure checked at shock trauma, you had an 85% chance of having a fasciotomy. You don't need to check. It's 9 out of 10 times it's positive. If you check them, you might as well just book them for the OR because it's going to be positive. Thresholds are really tough to set in medicine, right? We'd love to have the two lumps there apart from each other, but they're not. They overlap. And pressure is a really difficult thing. It's going to, pressure and blood flow is going to affect these different tissues in different ways. And it's different once they get injured. And there's another problem we haven't really even talked about that's a fundamental issue here. It's the definition of compartment syndrome. In all these studies, how did we decide what compartment syndrome was? We said it was compartment syndrome. That's basically it in most of the studies. They got a fasciotomy. So there's no good gold standard, and surgeon opinion equals a diagnosis, and there's no false positives. You get to the OR and you see muscle death. They could have died for other reasons, right? Vascular insult from the trauma, direct blow. If the muscle's alive, is that okay? Well, the goal is to get there when the muscle's alive. So that isn't necessarily bad. That's our goal. We want to get there when it's alive. Sorry, my screen slightly froze. There we go. Here's one that came out of McQueen relatively recently. So this is the diagnosis of a false positive. The diagnosis was incorrect. It was possible to close the fasciotomy wounds at 48 hours. So this is our leading researcher in the field, you could argue. And so I think this is a problematic definition, right? I don't go back at 2 days, so I'll never have a false positive. I've had a patient with a pressure of 110 who I closed very, very quickly. We've all had patients who you can't close their wound. They don't have compartment syndrome. So this is this is kind of where we are in terms of this issue. We have some progress to make, I think. So what new ideas are out there? I think to think about the new ideas, you need to think about the problem we have with pressures. And so Chris Dora really taught me about this. If you think about what's going on, the cells aren't dying by being crushed by the pressure. They're not like a submarine deep underwater. That's not what's happening. They're dying because of anoxia. So maybe we should check something related to that instead of checking this pressure. Analogy he taught me was, look, if you were trying to figure out if someone has a broken leg, you say, look, if a car hits you, faster cars are more likely to break your leg. We'll just ask how fast the car was going, and that will figure out if you have a broken leg. And that is true, but the speed is related, but that's not a great way to do it. How about getting an x-ray, right? And that's kind of what we're doing here, right? High pressure affects the blood flow, which affects the muscle, and that causes problems at the cellular level. And so we're checking the pressure. We're checking the speed of the car. We're looking at the wrong thing. And so a lot of people have proposed various tests and things that have done, and more have come up over time. CPK and lactate and all sorts of issues have been proposed. I just want to talk about a few of them that you might not be familiar with. So one is tissue ultrafiltration that Andy Schmidt has come up. And this is the idea of getting some fluid out of the compartment. And so you're going to measure pressures, but you'll actually suck some fluid out. And so this was FDA approved as early as 2004, and studies are underway in metric now to do this. So this is coming. We're actually going to try this to see if we can actually decrease the pressure in the compartment and see if that actually changes it. Another one which has a lot of interest is near-infrared spectroscopy. And so this is like the pulse ox on your finger. This is old technology. It's FDA approved. And there's a new version that can go below the skin to look at muscle perfusion. So that's super exciting, right? We could just slap this on a compartment and figure out if the muscle's doing okay. And it's complicated about how you interpret it because the oxygen levels go up in an injury. And so it's a little confusing how to interpret it, but there were some provocative studies that came out with people who were involved in designing it. So the downside, it doesn't measure and it wasn't validated yet. Well, the PAC study is just coming out now out of metric. And so now we know more. And so that same study we quote before, they took 185 of those patients and they looked at pressure data and they showed that about 9 out of 10 times you could get a good pressure measurement. It worked. You got a valid number. You could at least get a number. NIRS, only 9% of the time. So whether or not NIRS is a good idea or works, you can't even get a number out of the leg, right? So NIRS sounds like a great idea, but I think the metric study has shown at least that technology, it's not ready for prime time. And we've got a lot of work to go on that one. The last one is glucose. So Chris Doro has pioneered this. This is an idea that flap surgeons use for flaps. And the idea is that cells really defend glucose levels. And so maybe we could measure the glucose in the muscle. And there's lots of glucose monitors out there. And the question is, does it work? So Chris did a nice study in dogs, and he looked at this. And what he showed basically is that there's this profound and acute drop in glucose very quickly, and that cells do, that you can really tell this. The question is, we don't really have a great monitor yet. And so it's not clinically done. So if somebody's got an awesome glucose monitor, I'd love to hear from you. So, you know, and in this test, we have the same problem we always do. So let's say you came to me with that test and we want to validate it. How are we going to do that? How do we know who has compartment syndrome? We're still really struggling with that. So that brings us to the end. So in summary, I think we all need to really worry about compartment syndrome. This is a scary issue for the patients, most importantly, but for the medical legal system also, and particularly in the tibia and the proximal tibia, but even things like proximal fibula have a very high proportion that wind up with compartment syndrome. Documentation is key, both in taking great clinical care of the patients and also medical legally. There's unfortunately good animal data that time really matters. It's still an emergency. And the diagnosis really continues to still be difficult for us. If you think about the literature, I think it's fair to say that, including all the stuff we've been involved with, it's sort of horribly flawed. Now there's some better stuff, prospective stuff coming out of metric, and hopefully we'll make some progress on this. I would argue we really still don't know who has compartment syndrome really in any clinical study. I think we only know who doesn't have it. You know, people we haven't released who have good function, those patients we think didn't have compartment syndrome. But unfortunately, I think we still have a long way to go on compartment syndrome. Thank you for your attention. I appreciate you listening to me about compartment syndrome.
Great. Thank you so much. That was an excellent talk and a lot of interesting, new directions. I think, we would have some time to open it up for questions. Please feel free to unmute yourself and ask away.
Bob, thank you very much for that talk. Really a comprehensive overview of what I would agree is really flawed literature that guides our understanding of this problem. I'm really happy you highlighted the problem with the definition. I don't see how we're going to ever make progress in understanding better ways of diagnosing this problem if we have no idea what it is. And I think you really articulated that nicely. I mean, it reminds me of think about as like fat embolus syndrome, right? This kind of wastebasket term that really probably, encapsulated many different clinical entities that were affecting lung function in trauma patients. Where are the new ideas there? I mean, in terms of diagnosis, I mean, I think that there's a lot of cool tech, most of which, may not end up working, but there are a lot of really interesting ideas. But I just, without a gold standard definition, how are we ever going to move the needle on this problem?
Yeah, my personal bias on this is I think, and maybe this isn't the right thing to say since we're doing a bunch of studies in humans, is I think we got to get out of humans and I think we got to be in animals, right? Where we can actually control the model and they have compartment syndrome. There's a bunch of established compartment syndrome models in animals. And I think we have to understand this technology. I think the idea of going right into humans, we are so clueless about who has compartment syndrome. There's a huge chicken egg problem there and I don't know how to solve that. But I think we can make a lot of progress in animal studies, but they're very expensive, right? And they're also, it's not exactly the same. You don't get any physical exam. And so I don't have a great answer, right? You're like, oh, we'll use AI, AI will fix this, right? But in order to have AI, right, you have to, in general, most of these, advanced neural networks and all this stuff, right? Somebody has to bin the images into this is melanoma, this is not melanoma, right? That's the problem we're having. We can't bin the cases to feed it into the computer to say who has compartment syndrome. In these PAC studies and things, right, what was done is some complicated expert panel who decided retrospectively with prospective data whether or not the patient had compartment syndrome. I mean, is that better? I don't know that that's better. I'm not sure I trust 10 experts sitting in an office somewhere over you sitting at the bedside. Well, you're an expert too, but you know what I mean? You know, a person who's at the bedside. So I don't know. I honestly don't know the answer to it, but I'm skeptical that we're going to get there. I don't know. Do you have any thoughts?
No. No, I wish I did, but I'm on the same page. I mean, I've sat, at these meetings and talked about how these expert panels were going to ascertain whether it was a compartment syndrome or not. And it's fraught with all kinds of problems, right? The muscle could have died for a lot of reasons. One of them could have been pressure, but it could have been vascular insult. It could have been, a lot of problems. So I would agree. I mean, I think that's a really good point that because this is such a rare entity and it is so highly controversial in its diagnosis in humans, I do think animal models make a lot of sense. As a clinical researcher, it's hard for me to ever say that something like that, but I think you're right.
Yeah, I'm with you. And I don't do a lot of animal research either, but and I'm usually, my background's in biomechanics. And so I, often I'm like, it's a biomechanics study. You shouldn't really, who knows what that means. But in this case, I think maybe it's the other way around and we should believe that more than the human studies.
Thanks.
So I want to just chime in to follow up with that line of thought. And, again, thank you for coming. This is a completely provocative topic and very relevant. And you zip through what everybody needs to know in a very concise way. So thank you. It's obviously this is something you've thought a lot about. Part of the problem, though, is that, yes, we don't have a good definition for what it is clinically. We have a whole bunch of other things in science and medicine where we really are relying on the tools that we have to help us decide what the answer is. So if you're looking at the way bone heals, for example, it's something that I've followed for decades. It's only till more recently that we have a lot of the tools that we need to be able to determine some of the events that are happening. I think the same is true in this case. You put up the Stryker pressure monitor. So people are doing point of measurement pressure decisions based on, single data. You pointed out Paul Tornetta's study too, which also is brilliant. And the sensor technology is changing really rapidly. We're right here near University of California, Berkeley, and they're measuring all sorts of sensors, different types. You'll have your glucose monitor one of these days. And what I would say is that it is very likely that if we start using better tools to measure, it might not be a delta 30. It might be a change in time, a certain slope that we're following in terms of how these cells are behaving. So is it a pressure change over time? Is it a oxygen tension change over time? And this is, I think, going to help guide us a lot to help make better decisions. Because in the end, so some muscle may die, but what we're trying to prevent is all the muscle from dying in an entire compartment. So I know, for example, you're using some new technology that is out there that looks at pressure monitoring using a device that does long-term real monitoring. That's going to help us perhaps with the big data that we might need to. Any thoughts? So long-winded question. Do you have any thoughts about the new technologies that are out there to look at longitudinal data, not just single point information that you then have to try to develop some sort of dichotomous answer, yes or no, when really you're getting, this is really sort of changes over time?
I think that's a good point. And, that's sort of where this started, right? That's what the McQueen data, that's what they started with, right? It was continuous measurements. And so I think that makes sense. I think it is an evolving process. And I think, as you say, the slope may tell us a lot. I also am optimistic that, technology is evolving very, very quickly in all parts of society, and it will probably involve here. There is some economic driver. So maybe, that will be enough to drive it. The part that I'm pessimistic about is all of those things sound great as long as, to me, you're doing them in animals, right? As soon as you get into humans, I just don't know how you know anything, right? Like, so I give you a bunch of data. Now, what do you tell me about the patient? I don't know anything about the patient still. Like, did they have it or not? Like, I don't know how you figure that out. And so I guess that's my point is I'm not pessimistic that the technologies will evolve. I agree with you. I think there'll be some really cool stuff. But in terms of validating it or figuring it out in some rigorous way, I'm still just pessimistic about that in humans unless we're going to do some more fundamental work to really figure out, what that threshold is, what the slope should be, what the thing is. Otherwise, we're just going to make up something, and then we're going to, sure, and if it says to release 30% of the patients, we'll release 30% of the patients when the actual proportion is 1%. A lot of compartment syndrome studies, McQueen's, et cetera, the rate was 1% until she started checking everyone, and then it was 12%. And so those patients they got released, right? So nothing bad happened. So maybe you're releasing 12 times as many people as you need to, but you'll then validate it and you'll say, oh yeah, that's great. No one was injured. So I just think I don't disagree with you. I think you're right on that the technology is evolving fast. I just think that the problem I'm trying to point out is it's really tough to validate anything without knowing which patients have compartment syndrome.
Or having anything that is going to actually be accurate in what you're measuring. I think that's another problem. But thank you. That's great.
Yeah, for sure.
Hey, Dr. O'Toole, thanks for that. That was phenomenal talk. I was just wondering, in terms of your current practice at Shock Trauma, with regard to continuous compartment pressure measurement, in terms of technologies that are actually now more widely available, that is something we can do that's maybe a step forward from the Stryker measurements. Are you guys using that? And if you are, what are your indications for it? Is it obtunded patients or everybody that's at risk?
We've used it twice in 6 months. So to be clear, right, it's not... In the history of shock trauma, it's been used twice. It just happens to be the past 6 months. But so we do have it. We're, Dr. Slobosian starting to lead our look into that, but we have not, been doing it a ton. As you can tell from my bias, I think pressure measurements are sort of the wrong thing. And I think they have a very high false positive rate. And so I think they're super reassuring. And so if you measure someone and they have low pressures, from what we understand about the pathophys of compartment syndrome, you probably either missed it or it's not happening. But higher numbers, I'm not sure what to do with those higher numbers, especially numbers, where you have an absolute pressure in 40, 50, 60, and your delta P is 20, or, when you have a pressure measurement of 115, right, and your delta P is, 30 above diastolic, sure, right, that patient has, I got it. But that's often not the case, right? Those patients are sort of obvious. So we don't use a ton of pressure measurements. We tend to go to the ICU and make the resident take the splint down on those patients and examine them. Studies have shown that doesn't, in cadavers, we can't guess what the pressure is. So that probably doesn't make any sense. We tend not to use a lot of pressures. I know that if we used more pressures, I think we will release more patients. But you could argue maybe that's good. Maybe we're not releasing enough patients. What do you guys tend to do? What do you do for ICU patients?
Yeah, we've been really, very rarely use pressure measurements, I think, in the diagnosis, except in the really equivocal cases, either because the patient's obtunded or something like that. But we do now we just had some in service on how do you do continuous compartment pressure measurements, and that's going to be more widely available to us. So I think we now have this discussion of, if we have this continuous thing, is that going to change the calculus at all? Are we going to start to use it more, particularly in those patients where the exam is even less reliable, either because, they're intubated or they're have a challenging exam for whatever reason.
I mean, what's interesting, right? Like the way we sort of think about compartment syndrome in North America is, if you have compartment syndrome, you go to the OR. That's it, right? If you don't have compartment syndrome, you don't go to the OR. But, in the McQueen era, from what you can tell in the paper and from talking to people, they did stuff, right? Like the nurses looked at the number and said, oh, we maybe should loosen the dressing, or we should elevate the limb, or we should do this, or we should, like they manage the numbers a little bit, which isn't sort of how we think about it, right? Like it's an emergency, we have to go. And so that's an interesting thing too, right? Like if you were continuously measuring something, could you see this coming and ward it off? I don't know, maybe.
Yeah, I always have found the Stryker, the actual process of doing it, you inject the little saline, and the number goes way up and then it kind of drifts down. It's just like, doesn't feel right. Whereas like having this continuous number that you're following feels like it might be more reliable, but I don't know for sure, I haven't any experience with it yet. So I was curious if you guys have been implementing that.
We don't really have experience with it yet. Can't comment. It's coming.
See. Any other questions or comments from the group?
I could have one other question. I know that Sam's clapping and it's well deserved, Bob. So thank you. Could you comment? We have a lot of pediatricians here, and I know that there is an interest amongst our pediatric group on this topic as well. You focused a lot on the adults. Do you have any words of wisdom for the pediatric population?
I don't do kids. You know, the sort of classic teaching and classic papers are about looking for pain requirements and things, but I think it's you know, it's certainly not an easy diagnosis in kids either, obviously, and so it is. There's definitely literature on that in the pediatric population, but I don't think that makes it any, you know, as usual, right? It's even more difficult in kids who are tougher to communicate. Some of the adults aren't so great at communicating either, but I think that component really makes it difficult.
Yeah, Ted, thanks for asking that question. I'll jump in. This is Sanjeev Sabral. I'm a pediatric orthopedist. Really enjoyed your talk. You know, there's been a plethora of, and I'm sorry, I missed the first few minutes of your talk if you'd mentioned it, but there's a plethora of, you know, diagnosing compartment syndrome, let's say in the spine, in the thigh, obviously in the foot and the hand. Do you think we're sort of overcalling that as well, or that's something that we've missed in the past and sort of we're recalibrating to the lower leg and saying, hey, this is not a lower leg problem only, it happens in other places?
I don't know. So there's definitely, you know, we see it here, you know, gluteal compartment syndrome. We have a run of that. All of a sudden everyone's worried about that, and you see a bunch of those cases. And people have talked about thigh compartment. You know, are we missing a bunch of thigh compartment? We have these patients that have these incredible elevations of CPK and renal failure. No one can find out where is it coming from. I'm sure there are some missed cases of it, and I think you can kind of get it anywhere. You certainly can get it in the foot, although I must say, you know, that's another sort of controversial area, is that in our center we tend to not release that, although I feel like I almost never see it. And part of the reason for that probably is most of those injuries that would develop it, we tend to operate on acutely anyway. So we're essentially decompressing them by fixing their talus or doing their Lisp frank acutely. We almost never wait on those injuries, almost regardless of swelling. And but yeah, I don't know what the right answer is for those. That's even harder, right? Because at least in the tibia or tibial plateau, you got 1 in 10 patients is going to have this issue. So yeah, it's rare, but it's not that rare. I mean, it's happening, you know, on a weekly basis. Spine, other places like that. Now you're talking once a year, you know, that's not a common thing at all. So I think I really am, not to be a Debbie Downer, but I'm really pessimistic about our ability to figure that one out. What do you think about it?
Yeah, no, I mean, you know, again, I remember I came from another institution, but we had like a couple of them, you know, post-traumatic sort of paraspinal increased pain pressure. And, you know, somebody went ahead and released it. And it was like a, you know, wow, you saved this kid's back or something. And, you know, I'm not convinced that happens. So I really honestly don't know whether that was the right thing or not. But I must say, you know, it seems like it's coming up more in journals and case reports and this and that, especially the thigh and the butt. You know, I mean, those sort of seem to be catching more attention.
Yeah, I think that's right.
I have a question, Dr. O'Toole.
Dr. Ding, how are you? Pleasure to see you.
Good to see you too. Sorry you can't come out here. What do you do about the cases where the time frame is unclear? I know you talked about acute compartment syndrome and these trauma patients are just coming in, but sometimes you get these calls where like, oh, patient's found down, maybe for a day, maybe for 3 days, and the compartments are firm. What do you do about the delayed cases where, like, you know, you're concerned that if you don't release them, they have ongoing compartment syndrome and they'll lose a leg, or that the leg is already dead and you open them up, you put them at risk for infection with all the necrotic tissue?
I thought this would be the first time I've ever given a compartment syndrome talk and didn't get that question. So I'm glad my streak is still alive. I was at a fellows course and someone asked this question. So it was a bunch of ortho trauma faculty from around the country and fellows, and someone asked that question and then I gave an answer and it started like a 20-minute verbal fist fight. It was awesome. So I will try not to cause that again, but I'll try to give a different answer maybe. So it's a really hard question, and nobody knows what to do. What's my answer to like everything you said, but I can tell you what my personal approach to it is, which is different from what other people do. And I can tell you, I was just on a call with some other people. I can give you Andy Schmidt's approach to it, which is totally different than mine, I think. So my approach is I look at the patient like a brand new patient. I ignore the time course. So if they have signs and symptoms of acute compartment syndrome, I will release them. So if I think they have pain out of proportion and all this stuff, I'm not afraid to release them. My experience has not been that they wind up with amputations. My experience has not been that it releases the poison into the system. I just did one a couple of weeks ago. The patient, I checked their CPK every day and their creatinine, nothing happened. They had a whole dead compartment. I took the whole compartment out. In the end, there was nothing I wound up saving. But when I first got in there, I thought there was going to be partially saving. So my experience has not been that I think that literature is a little bit of misreading of the crush literature. That's a different topic. Your limb is crushed under a building for 3 days and then you're brought out. Your skin's damaged, your bone's damaged, everything's damaged. The skin cannot heal. That's different than a compartment syndrome that was missed or an untimely diagnosis. That skin heals just fine. And I don't think you lose those patients' legs personally. So I will use pressure measurements in those patients more often. And if their pressure measurements are low, that also reassures me that I missed it and it's over. If the patient doesn't have pain, if they seem like they're late, then I tend to not do it. Andy Schmidt's answer to this question, I think, would be you shouldn't open them. There's no benefit. The renal failure CPK should not ignore it. It should not push you. That is transient. It'll come back down. They might have to go on dialysis, but it won't be permanent. I'm not saying that facetiously. I mean, seriously, it'll be fine, and just ride it out because you don't want to open them up because nothing good will happen if you open them up. I've seen medical legal cases where someone's like, the compartment syndrome was missed 4 hours ago, so we don't want to open them up. And so, I mean, I'm not so sure how you know that, right? Like, it seems to me you're right in the middle of it evolving. You could save that function if you open it. So it is a very difficult area. No one knows the right answer to this one for sure. That's my personal approach to it. What do you do? What do you think?
I'd sort of gain more of your approach, not surprisingly. But I've certainly been burned too. And, I had a case in hand fellowship where a guy with Parkinson's was just down for an unknown period of time. I got called. It sounded like there was ongoing compartment syndrome. I released him, but then everything just died. The skin died. I was staring at interosseous membrane like a week later. So it's just something that's really hard. And we're certainly biased by our last case.
For sure. Yeah.
Great.
I'm glad it didn't sound like it started a big fight. So that makes me feel like my answer is getting better.
Well, and Tony timed that at the very end. So
no time for fighting.
But Dr. O'Toole, thank you so much for joining us. And we definitely wish it could have been in person, but hopefully at some point in the future, we'll be able to get you out to San Francisco. And but I know we all really appreciate your insight, and thank you all for joining this morning.
You bet. I appreciate it. It was a real honor to speak and spend time with you guys today. Have a great day.
Bye, Bob. Thank you.
Thank you so much, Bob.
Thanks a lot.